So you might automatically think that health literacy means that it reflects somebody's ability to read a pamphlet on health, but in fact, health literacy is much more profound than that. Health literacy involves understanding social, environmental, organizational, and political factors affecting health. So, if we cast our mind back to the definition of health promotion, health literacy is particularly important because health literacy is all about empowering individuals and empowering groups to basically determine the future of their health. So to engage in debates about local health issues, to basically steer the environment towards enhancing health. And part of this process is actually about learning how to advocate. So if we think about the first assignment, which was the health advocacy piece that you are presenting or have presented in the recent week, it's all about knowing the various factors, social, environmental, organizational, political factors about a particular issue, and being able then to collaborate towards engaging debates about changing the environment for the better in terms of better health outcomes. So we talked about health literacy being an important aspect of health education. If we think about now the principles of effective health education, just like with any intervention, health education programs really need to be carefully planned, and they need to be very mindful of the needs of the particular group in question. Too often, public health people in the past have assumed that they knew what the particular health issues and concerns of a population were without actually ever asking them. And to get full engagement by the community, we need to make sure that their needs are being recognized and met. Programs need to be, of course, culturally sensitive and appropriate. And again, this requires quite a detailed understanding of the cultural, social, and religious context within which one is trying to practice health promotion. So, as this said, the social context in which people live, very important aspect. It's not just good enough to have a one-size-fits-all approach to particular health issues. So we also need to understand about determinants. So this is why we spent the last few weeks exploring the issue of determinants. A health problem, basically all the different factors that contribute to the development of this particular health problem, whether they be proximal determinants or ones that are more distal or even global. And finally, there's some keywords here in terms of what health education programs should be. They need to enable people, they need to engage people clearly, and they need to empower people. If you can't engage your population, then they won't take any notice of what you're trying to achieve. So if we look at one particular example of a recent example of the last 40, 50 years of health promotion, there's the issue of smoking. We can have a bit more of a look at the anti-smoking campaign from the perspective of health education. So the health promotion against smoking focused on changing individual behavior. And this is the same with alcohol and also diet-related health promotion campaigns. In terms of smoking, the main strategies were a combination of fiscal. So fiscal means related to tax and money. So increase in taxes, health education. So there is a lot of material produced relating to the health dangers of smoking. If we think about the smoking ads, again, they're very much focused on individual behavior in terms of treating smoking like a poison. Certainly images of very necrotized lungs, for example. And then by comparison, we can have a look at the Slip Slop Slap campaign, which was basically this campaign to educate the public about the dangers of UV radiation in terms of risk of skin cancer, and even more seriously than skin cancer, melanoma. The prevalence of these diseases is Australia, and particularly Queensland, has the highest incidence of these diseases in the world. So if we think about the Slip Slop Slap project, not so much about fiscal restrictions or fiscal mechanisms to steer people's behavior. It was much more about education, health education, and mass media campaigns to educate people to protect themselves against sun exposure by using appropriate clothing, sunscreen, and also hat. And one of the major challenges with this is that often the exposure is a very long time away from the actual disease. And the longer this distance is away, the more difficult it is for the health relief model to actually engage the population. And one of the issues here is that, for example, a lot of, if we're talking about skin cancer, a lot of the exposures that may lead to skin cancer happen very early on, very distally from the actual disease. And so it's very difficult to change people's behavior when it's not quite clear that there's a relationship between the disease outcome and what may have happened years previously. This is a major challenge. If we look at a little bit further to try to classify, understand models of health education, we've got clearly a range of different models to use. The most tried and true is the medical model, where you've got basically a doctor-patient relationship. And the idea is that the doctor has a far greater status in terms of knowledge and expertise and social rank or position than the patient. Now, this is pretty much an outdated concept of the role of doctors within society, although in some countries and in some subgroups within society, that still is very much prevalent. So basically, you might ask somebody why they're doing something, and they say, because my doctor told me so. So that's that model. There's also another model in terms of health education that's quite extensively used, the knowledge, attitude, behavior connection. And again, knowledge and practice, the relationship between these two quite often is basically broken in some way. And so it's recognized that it's not only knowledge that's important, but the person needs to actually change their attitude about a particular issue before behavior can then change. Educational models, so much more formal education of consumers or of the population to get them to be changing their behavior. Very much the three following models actually relate most to health promotion. Empowerment model, because health promotion is largely about empowerment, empowering individuals and communities to take charge of their own health, communities in particular to take charge of the health of the community, so community action, and also social change, because many, if we look again at this simple diagram where we've got all the determinants of a particular health issue, a lot of these factors actually are based on social factors, sociology of a particular community. And so we require, if we're going to have change here, we need change here. Now, this last point relates mainly to the medical model, where you've got a real differentiation in power between the doctor and the patient. And whilst in the past people would actually change their behaviour because they were told to, a large proportion would, because the differential in power and influence and status between doctor and patient has changed substantially over the recent past. This particular approach to health education seems not to be particularly useful in the Australia of today. When we're considering the modes for successful health education, we need to understand how it is that people learn, and also how do they convert those learnings into some sort of action. And this slide basically, it's not so much of interest because of its the content itself, but suffice to say that there are a range of different understandings and theories on how people act out their knowledge, from behaviorists to cognitive theories to humanistic theories, and different people have the different ways of learning. And if you're engaging in health promotion and health education interventions across the population, then you need to cater for these different ways in which people learn and therefore act out their learnings. One particular interesting way of learning is experiential learning. So, and this relates to people living through an experience and learning from that experience. So essentially the way it works is that you try something, you see how it works, and depending on how it works, you either go in one direction or another direction. And as we become older and have more experience in a particular topic, we tend to rely more on experiential learning rather than theoretical learning. But suffice to say that there are a number of different ways in which people learn, and in health education we need to be aware of those different methods. As a way of summarizing the principles of imparting health education for behavior change, which is essentially the objective of health education, there are some important things we need to do. We need to identify the factors that influence health beliefs. We need to explain how theories of motivation and models of health belief can assist health promotion activities. So how do we motivate people to engage? It's not just good enough to say, for example, you need to eat more vegetables. You really need to get your target population interested in the idea of eating more vegetables, so they actually engage in the behavior rather than just engaging it theoretically. And part of this involves, well, how do we as health educators actually motivate clients? And it all revolves back to these factors which influence beliefs and therefore behaviors.